All right, are we ready for the next session? That's gonna be interesting session on weight loss and body shaping. So our first speaker, Dr. Gastova Torres de Zalsa.
Hello.
You ready?
Thank you.
Okay.
Hello, everyone. Well, I don't think I need that.
Genetic profiling for personalized weight loss intervention. SNP association, interaction, and pathway insight.
Exactly.
Very interesting.
Thank you. Thank you all for being here. The aim of the session isn't to go too much deep into genetics itself, which is my field, but rather to resonate a bit with what we will see in the session and also what I have seen, for instance, in the sessions on GLP-1, which I also presented a bit of our genetic insights into it, which is this question, or probably these three questions, is if patients respond equally to therapies. So when it comes to pharmacological therapy, this is not true, so not all patients respond equally. And when it comes to weight loss, and we have all the modalities of weight loss, we have the nutritional diet therapy, medicational therapy, so as the GLP-1, I'm not sure if anyone was in the GLP-1 talk earlier. And obviously we have all the body shaping applications plus the bariatric surgery. And the weight loss per se is always going to be one of the bases of anything done in view or aiming at body shaping. And the reason why I'm asking this and the reason why I'm bringing genetics into this conversation is really to discuss a bit with you how can it be improved so that we have better outcomes in the patients. So the first thing first is that, weight loss is important whenever we are talking about improvement of health overall, body shaping, and so on. So then it comes the question, firstly, do all patients respond equally? No. And then we go to one of the answers about this. We have a range of response of weight loss when patients are doing diet or any intervention that ranges from 40% to 80%. But this really depends on the study, and I tend to see that it lies here on patients losing weight only like less than half of the time. And what we have also seen in the literature, and this is an important aspect, is that when patients are better guided, so when they understand their bodies better, they adhere better to therapy. So they adhere better to diets and so on and so forth. And one of the best findings was that when patients were guided by genetics, so when they were genotyped and we know what they need in their diet, what are the predispositions to deficiencies, how is the appetite of these patients expected, the adherence improves. And so we go to the aim of using genetic, which is improving adherence of patients to the diet, and also to understand these patients better. So when we do genetics, or when we apply genetics to that, or to patients overall, what happens is that we know better the patients, and we know the patient's biology, how they work better. And this is really the aim, like just two basic concepts on what is nutrigenetics and nutrigenomics. So when we talk about nutrigenomics, is that we know that for sure we have the interaction between nutrients and the functioning of any or all the cells in our bodies, and they are both influencing how genes are expressed and how how the cells work, but also when we go to the other way around, we have in nutrigenetics mostly the fact that some genes, some of the ones we have summarized here or exemplified here, they do interfere in how we respond to the nutrients and to diet in general. So we have, for instance, alterations in cholesterol, in the needs for protein, in the probability or propensity to deficiencies in vitamins and minerals. All of that is pretty much aligned and pretty much predisposed by genetic predisposition. What is genetic predisposition, so that we can finally, or what at least allows us seeing or understanding genetic predisposition, so that we can finally go into the theme of the study itself and how it can be applied to patients, is this. So just so you understand, whenever I talk about a genetic variant or a SNP, this is what a SNP looks like. So let's say we have a region of the DNA. All of that in blue is a certain region in the DNA. And most of it is the same. So if you take the blue part, it's always the same across all the patients we have. But we do have one single region or one single letter that changes across the patients. And this is what we call a SNP, or a single nucleotide polymorphism. And why is this important? I know genetic has been behind everyone for a while, but the important thing is that this is the genotype. So this is what we can see in the laboratory. And these SNPs are the type of genetic variants that are mostly correlated to phenotypes that are clinically actionable, so clinical alterations we see in these patients. So this is all technical information, it's all very basic, so some of you will be very, very bored about that. However, what we have also done is that this was turned into a study. So we have selected 109 SNPs, or genetic variants, as you have already seen how they work. And we have tested patients across the globe. So we have retrospectively tested patients for weight, BMI, and weight loss across 9,000 patients across the globe. And we did this in 2 data sets. So the first data set was one in which we had simply 9,000 patients in which we had the anthropometric measurement, so essentially BMI and everything. And we did a correlation to the unique SNPs we have found. This has allowed us, firstly, to understand as a baseline if the SNPs we were analyzing, so the 109 SNPs we were analyzing, they did correlate to weight. So we wanted to know if and how the genetic analysis we were doing did correlate to weight, per se. When we talk about weight, like gaining weight, we have this balance between what enters in the body and what exits the body. And although genetics is one of the factors here, what we have seen and what I will show you is that during weight loss, weight gain and weight loss, what happens is that genetics does correlate to many of the factors that lead us to eating more and also spending less energy. So although this interplay is a complex interplay that has many things, genetics is involved in many of them. So there are many of those very known genes. We are going to understand them slightly better. And I'm going to point out here to one important gene, that is the melanocortin receptor gene, this one. Because this gene is essentially one of the reasons why our brain, so the central nervous system, so in the hypothalamus, does or does not recognize the outer, so the peripheric interplay that signals to satiety. So although obviously we have the GLP playing a role here, as we have already seen in the GLP talk, when it goes to the brain, there's also some factors related to satiety that will also be related to one more interplay. So we do still need at least as we have seen, one of them is going to be the melanocortin receptor here in the hypothalamus. And why is this important? When we analyzed these 109 SNPs in these 9,000 patients, we have found these 11 SNPs to be very well correlated to weight per se, so BMI. So the FTO gene, everyone knows, the MCM6, these genes, and the melanocortin gene, obviously, and the GPX gene, very known genes that are related to appetite. Why is this important? This is important because we know, so when we look at the body and where these genes are mostly expressed, we start to understand why patients gain weight. So we start to understand that if patients don't have a very good response in the melanocortin receptor, for instance, they're not going to feel satiated, and then obviously they're going to eat more. And obviously we have many other genes which are peripheric genes that are either related to how patients signal to upstream in the central nervous system, or they spend energy peripherically. And that gets us to the second data set we had in the study. So the second data set we had in the study is the patients were weighed before. So we had the BMI before, and we had the BMI after patients being subject to either diet, balloon, or bariatric surgery, sleeve bariatric surgery. And why was this important? Because we were able to see not only the factors that led to being overweight, but rather the factors that are related to being overweight, but to weight loss. And this comes to the very aim of using genetics here and the correlation of it to the body contour, to body improvement in general and body shaping, which was this. Weight loss with diet, weight loss with balloon intervention, and weight loss with bariatric surgery, they did correlate to different genes. So we had a group of genes mostly correlated to responding well to diet, responding well to balloon, and responding well to bariatric surgery. And this is interesting because these have different mechanisms. So some patients will lose weight better with diet because they do have, for instance, alterations in the COMT enzyme. So probably the problem is not related to satiety, but rather to some compulsion in eating. This is just speculative, but I mean, this shows us something. Or some patients might need a bariatric surgery because the melanocortin gene, again here, is alterated and the central nervous system is not responding well to satiety. So they actually need a physical alteration in the tract, in the gastrointestinal tract, to avoid eating so much. And obviously, then we have again, so things which are related to diet and to bariatric surgery in the central nervous system, and also responses altered to diet, balloon, and bariatric surgery, also being influencing genes which are expressed outside the central nervous system, but rather in the peripheric system. So, like for instance, the PPRD, which is involved in fatty acid metabolism, everyone knows, and the leptin, which signals back to the central nervous system for satiety. Well, I'd like to thank you very much, and also put myself obviously available if you have any doubts. Also, if you need any information related to using genetic testing, anything, just please let me know. I need to apologize to the board because I have another overlapping session, so I'll need to leave. But
Do you want
I'll be
to
here.
take a couple of quick questions and no
Yes, I
more?
mean, yes, obviously.
That was so incredibly fabulous.
Thank you.
you so much
Thank you
for
very
sharing.
much.
Anybody have a quick question? Is this work published somewhere?
This work is published. Sorry, I didn't mention it, but yes, this study, the first study was published here in 2024, and we have a prospective study happening at the moment, and we aim to publish another study with a GLP-1 part in the end of this year.
And do you have an anticipated journal that we can look for?
Yeah, for this one, it was published in the Frontiers in Nutrition.
Okay.
Okay, and very likely the GLP-1 is going to be in the scientific report, the Nature scientific report.
So,
But I will share with you. I mean, obviously, next Congress. I mean, the aim for Paris is for me to.
So next time, bring a QR code so we can download it. Or do you have one?
Yeah. This, if you can take the name. So this study is going to. This is easy. But if you need to contact me, I can also send you any information you might need. I can leave you my email or phone.
Okay. Thank you so much. We'll let you get to your next panel. And
I'll be downstairs. See you
Okay,
guys.
Thank you.
Bye bye. Thank you very much.
all right. Our next speaker. Dr. Dora Rosa Abraham, deep fasting, metabolic effect, autophagy, mitochondrial biogenesis, and implication to longevity.
Good afternoon, everybody. It's an honor for me to be here to exchange knowledge with each other. I want to thank the organizing committee for this opportunity. I have no conflict of interest to express in this presentation. The environment, as Dr. said, has more control over genes, protein synthesis, and hormonal pathway than we think. This chart from diabetes prevention program shows that lifestyle enhance fasting glucose levels as well as metformin treatment. This example demonstrates that diabetes is not a lack of metformin in the body. It's the result of alteration in the body, basic function, by the environment. We must create a better environment to optimize the function of each organ, each tissue, each cell, and each protein. Now, mitochondriopathy is being studied a lot since there is a structural damage to this organelle. Not only decrease the production of energy, but also the synthesis of protein and hormones. For this reason, we need to promote mitochondrial biogenesis. This is a curious case how deep fasting active energy efficiency, cells recycling and organelle protection process. Angus Berry from Scotland made a deep fasting during 1 year. The human body has a high capacity for metabolic adaptation in the face of extreme calories restriction. Look the date. He started 25 June and finished June 11 next year. Temporary energy restriction can reset hormonal and reproductive system, and reintroducing correct stimuli produces an improved functional reactivation. This shows that the body can stop non-essential function to survive, and then restart regenerative processes when the environment improves. Deep fasting is the absence of caloric intake, as you can see, during long enough to activate the beta oxidation. This time depends on the quality and quantity of the last meals we take, the metabolism of the people, physical activities, and general health of each person. There are three types of this process. In the first phase, if you can see the chronobiology, in the first phase, there's a glucose dependence with mTOR activation. In the second phase, the fatty acids are used because glycogen depletion. In the third phase, the mTOR inhibition and MPK is activated. In the last phase, the cell's growth halt and autophagy is activated. The autophagy removes defective cells, organelles, metabolic waste, and this is regulated by insulin-glucagon axis. These are physiological changes in each phases of deep fasting. And these are the levels of beta oxidation that exist for each phase. During deep fasting, beta oxidation produces ketones, and this is full for brain, muscles in absence of glucose. These are the hormonal change during deep fasting to compensate for hunger. The benefits to activate MPK is promote autophagic genes. As you can see, MPK activation and high ketone level starts autophagy. Yoshinori Osumi showed that the cell can degrade damaged components, recycle defective organelles and proteins, adapt to stress and lack of nutrients. This is what autophagy recycles. autophagy helps function heart, as you can see, nerves, muscles, collagen, elastin, thyroid function, promotes good health, immune system, and helps in tumor suppression. Measuring autophagy in human during fasting is challenging because there is not accessible, not invasive direct method for routine clinical use. It relies mainly on indirect biochemical markers detected in biopsies and blood. We need to promote constant hydration, progressive increase of fasting, keep training during deep fasting, and stress control. The high intensity interval training stimulates mitochondrial biogenesis. In addition to this, we must promote biogenesis with HIIT and zone 2 exercise, adding controlled calories restriction to induce mitochondrial autophagy. It's contraindicated deep fasting during pregnant, breastfeeding, eating disorders, and some pathological processes. These are important clinical studies of autophagy. The Institute of Functional Medicine recognized deep fasting as a therapeutic tool to improve the quality of cell regeneration. The International Society of Stem Cells Research suggests calories restriction. Here I leave some bibliographic sources. Thank you very much for your attention. Thank you, committee.
Thank you so much. That was really very interesting. Our next speaker is Dr. Estela Sechuan, who's going to talk about from weight loss to body recomposition. And this is a subject that's very interesting to me, preventing sarcopenic weight loss with hybrid nutrition and high-FEM protocols. So I wrote a couple of articles on high-FEM and sarcopenia, so hopefully you'll further educate us. Thank you so much.
Thank you for the introduction. Good afternoon, everyone. My name is Evania Astela, a clinical nutrition physician from Indonesia, and today I will present a case series entitled From Weight Loss to Body Recomposition, Preventing Sarcopenic Weight Loss with Hybrid Nutrition and High-FEM Protocol. The main idea of this presentation is simple. The aesthetic medicine should not only focus on making people not only focus on how much weight the patient loses, but also what kind of tissue is preserved, how the function is maintained, and also how the result look clinically. We often see people lose their weight, but somehow they don't get better. They may look smaller, skinnier, but less defined, look older, or even more fatigued. The problem is not the weight loss itself, but the problem is the weight loss without muscle preservation. In traditional slimming medicine, we often only focus on two things, the visual improvement and also the number on the scale. This can be achieved by injection, devices, or even aggressive caloric restriction. But if the muscle is lost during the process, the final result may compromise the body contour, and then metabolic health, functional strength, and also long-term durability. And this is the paradigm shift I would like to highlight, that the traditional endpoint is the scale reduction, so the body weight goes down. but scale doesn't really tell us whether the patient lose fat, muscle, water, or combination of those. But the body recomposition approach, we measure what patient actually value, which are strength, contour, definition, and durability. In aesthetic medicine, we should not only focus on making people smaller, but also metabolically and functionally better. So the clinical target should shift from the weight loss alone towards the fat loss with skeletal muscle preservation. Because we know that muscle is not only a structural tissue, in aesthetic medicine, muscle works as a contour scaffolding. It helps to support shape, definition, and also posture. Muscle is also a metabolic organ. It contributes to resting energy expenditure, a glucose disposal, and also long-term metabolic resilience. So in clinical perspective, the loss of muscle in weight loss program, it may harm the metabolic health and also the long-term weight regain. That's why muscle preservation is very important, not only for body contour, skin support, but also for functional strength, metabolic health, and also long-term sustainability of the weight loss itself. Here is the case series presenting the clinical nutrition-led body recomposition with HiFM as a local adjunct muscle stimulating technologies. So the patient, we do the assessment for baseline anthropometry and body composition, dietary intake analysis, and also visual improvement. The patient underwent approximately 4 months of hybrid protocol for medical nutrition intervention and HiFM protocol. For medical nutrition intervention consists of controlled energy deficit, protein adequacy, and also micronutrient optimization. And for the HiFM, we targeted abdominal area for 2 times a week for 4 months, so total 16 sessions for the whole process. And then we do the follow-up monitoring, weekly for dietary intake analysis, and every 2 weeks for anthropometry, body composition, and also muscle strength, and also the visual improvement before and after finishing the whole program. And this is the cases of 2 male patients. The first one is 27 years old with overweight nutritional status, and the second one is 42 years old with overweight nutritional status. Both have shared the same clinical goal, which is to reduce fat mass, to preserve muscle mass, improve abdominal contour and muscle definition, and also preserve muscle strength. Both patient is not only treated by simply the goal of weight loss, but to achieve the better body composition. So from this slide, we can see that nutrition was not a supportive care. It was the metabolic foundation of this protocol. The energy prescription was controlled, not aggressive, but we use approximately 28 to 30 kilocalories per kg actual body weight per day with adjustment of follow-up meal analysis. And also protein adequacy, we optimize up to 1.5 to 2 grams per kg actual body weight per day. And this is important because the protein adequacy during the caloric deficit, it helps to support muscle protein synthesis and also lean mass preservation. And also we do optimize the micronutrient by supplementing magnesium and vitamin D to support muscle contraction, muscle recovery, and also deficiency optimization. So the nutrition strategy is not eat less, but also control energy intake, protein adequacy, and micronutrient optimization. And both patients didn't receive any oral or injection medication for the weight loss, only a personalized nutrition prescription. For the first outcome is the anthropometry and body composition. We can see that both cases experience a significant body weight reduction as well as fat mass reduction and body fat percentage. And for the skeletal muscle mass, we see from the first case, there is an increment of skeletal muscle mass up to 1.4 kg for 4 months. So this shows the actual body recomposition, fat loss followed by a skeletal muscle gain. As for the second case, the skeletal muscle mass is preserved until the end of the program. So both patients showed that fat loss occurred without clinically meaningful skeletal muscle loss, suggesting that structured nutrition and muscle stimulation may support muscle preserving weight reduction. As for the muscle quality outcome, we know that body composition, we only see the muscle quantity, but we also assess the function of the muscle by doing the 1RM testing for movement of leg press, bench press, shoulder press, deadlift, and also squat. So both patients underwent the usual regular resistance training program, and both cases showed a significant improvement of muscle function despite of weight reduction. And what interesting is 1RM movement improved not only in a targeted, high FEM targeted abdominal area, but also in all major muscle across the body. So this is the outcome for visual clinical photography. We can see that both cases showed a significant improvement of muscle abdominal contour and muscle definition. In this part, high FEM may give the most major local role for abdominal contour improvement, as it directly stimulates the abdominal target area through supramaximal contraction. So we can interpret that high FEM may give the most visible local driver for the abdominal contour improvement, while nutrition ensure that the fat loss occur without sacrificing the muscle. What interesting from these cases is there are different visual responses between the two patients. We can see that the first case, the patient show more prominent abdominal contour improvement than the second cases. This might be due to the age and anabolic responsive, that the first patient is younger than the second patient, so it might give the different recovery capacity and also hypertrophy response of the muscle. And also, we don't do the testosterone testing, as it age-related androgen might partly influence the visual definition, and also the similar muscle quantity doesn't always reflect the same muscle look visually. It depends on the muscle density, muscle tone, and fat distribution, and also other factors like skin elasticity and also regional subcutaneous fat distribution also matters. And the limitation of this study is that we didn't do any ultrasound measurement for the abdominal muscle thickness and also subcutaneous fat thickness. MRI would be proper, but in a clinical setting, ultrasound may be more practical. And we also don't do the hormonal profiling and metabolic marker, as it might give an improvement as an additional benefit for the body recomposition. So for the conclusion, weight loss is not a body recomposition, and muscle preservation matters. Precision nutrition and high FEM may optimize the visual and functional outcomes. So the future medical slimming should not only simply reduce weight, but also preserve muscle, optimize contour, and also maintain function. As clinical nutrition drives a systemic muscle-preserving weight loss, while high FEM support local abdominal contour and muscle definition. Thank you for listening to my presentation. May God bless you.
Thank you so much. Our next speaker is Dr. Choi, who's going to talk to us about multimodal shoulder contouring, combining neuromodulators and fillers using the deep plane approach.
Oh, okay. Hello, everyone. Thank you for having me here. I'm Dr. Kang-Won Choi from South Korea. And today, I would like to talk about the multimodal shoulder contouring. And this is the outline of today's talk. And the part I really want to focus on is the anatomy here. for those of you who haven't started the shoulder filler yet, it would I hope this gives you the courage to begin. And for those who already do a lot of shoulder filler injection, I hope it gives you more certainty and the confidence. So we don't have much time, so let's jump right in. So before I begin, I have no conflicts of interest to declare for this presentation. So these are the virtual BNA image using AI. The difference is in the neckline and the shoulder line. The photo on the right clearly looks more feminine and more well proportioned. So why is that? The reason is something called the Ebbinghaus illusion. Look at these orange circles. The circle on the left definitely looks more smaller, but as you all expected, these two circles are exactly the same size. This means we don't see the circles by itself. Our brain judges it relative to the things around it. So this is exactly why the woman's face on the right looks more smaller and better proportioned. So even though the faces are actually the same size. So in other words, the shoulder frame creates the illusion of a smaller face, and to me, this is what the shoulder filler is really for. So now let's move on to the anatomy, and we don't need to know all the anatomy of the shoulder. We just need to know about this region's anatomy because this is where we want to inject the filler, all right? So let's start with the lateral view. In the filler procedure, the most important thing is the vessels, especially the arteries. And in the injection area, the vessels we see are the branches of the cephalic veins, but it's just the veins. So if you use the blunt and large bore cannula gently, we can avoid the rupture of the veins and rupture of the vein. And so then, where are the arteries that we worry about the most during the filler injection? The arteries are located underneath the deltoid muscles, like this. To reach these arteries with a cannula, you would need a lot of force because the fascia covering the deltoid muscle is quite thick. Even in the cadaver dissection, it's a fascia that is pretty hard to dissect. So in the anterior view, can see the cephalic vein running through the deltopectoral groove along with the deltoid branch of the thoracoacromial artery. But this is not the area we usually inject. So we don't need to worry about it too much. And this is the posterior view. And we can see the posterior circumflex humeral vein in our injection area. But again, it's a vein, so it's relatively less of a concern. So, which layer should we use in the body filler? There are several options, but I personally use the deep subcutaneous layer. The reason is that the layers of the face and the body are different. Firstly, the body has a little deep fat layer that can act as a space in the face. Secondly, the skeletal muscles of the body are covered by a thick fascia, so going deeper than the subcutaneous layer is not so easy. So, unlike the face, the subcutaneous layer of the body has a bilaminar structure. The SAT sits in the superficial layer, and the DAT sits in the layer below, and the two are divided by the superficial fascia. So, and if you look at the stained image right here, you can clearly see that the ACT and the DAT are divided by the superficial fascia. And interestingly, these two layers have the different histological characteristics. In the SATs, the septa are thick and dense, and the septas are more strongly connected to the skin. On the other hand, the septa in the DAT is thin and oblique, so it's more mobile and works as a sliding layer. This is just my own thought, but I believe that because the DAT has these properties, it acts as a cushion for a muscle movement, and so the muscle and the skin affect each other less. So I perform the procedure with the patient sitting upright, and that's upright. And for anesthesia, I used tumescent solution for the entry points and area around the acromion, because the acromion is where the patients feel the most pain. And I used, as I used the deep subcutaneous layer, and I used 17 gauge cannula because the body filler has very high viscoelasticity. So if you don't use the large bore cannula, it honestly feels like the syringe is like penetrating your palm. So I recommend to take the large enough cannula. And this is how I design. First, I mark the acromion, and I palpate the glenohumeral joint and mark the anterior and posterior point of the joint. And lastly, from the frontal view, I mark the most laterally projected point of the upper arm and connect these 4 points, and these areas will be the area you want to inject the filler. And for entry points, I usually use these 3 entry points, but usually I do that, but sometimes I make an entry point wherever I want, because as I said, there are a few critical anatomical structures in the injection area, so it's relatively safe. And if we add botulinum toxin to the trapezius like this, I usually use the 100 to 150 units per side. And on the deltoid, like this, we can make we can make the shoulder line and the neckline more elegant and more feminine. So here is the short video. Yeah, the filler I use comes in 1 cc syringes, so I collect the 5 cc into a 5 cc BD syringe, and yeah, it's something like this. Okay, I want to jump. Yeah. First, I design with a sitting upright, and mark the area I want to inject the filler, and as I said, draw the circle lines, and anesthetize the entry points using tumescent solution. And I use the 17 gauge cannula like this. So if you're in the right layer, if you tent the cannula like this, if you don't see the cannula clearly or feel the cannula clearly, you are in the right plane. If you can see the cannula or feel the cannula, that might be a little shallow layer. Yeah, let's let's move on.
So what is a layer injection again? I'm sorry.
What's that? I'm sorry.
Layer injection.
I use the deep subcutaneous layer.
Deep subcutaneous.
Yes,
Okay.
just above the fascia, deltoid fascia.
Above the fascia.
Yes, yes. So let's look at some cases. For her, I injected about 30 cc's. So as you can see here, after the procedure, the neckline and the shoulder line came alive. So it looks more feminine and more elegant.
Is that 30 cc's per side or 30 cc's
In total. In total, yes. And the second case is the male patient, and he had relatively a little deltoid volume, and which he didn't like the most. So I used the 60 cc's of the filler to bring back the deltoid volume, and he kind of liked it. And another case, and the patient's shoulder line also became much more feminine. And this patient felt her shoulder line looked too sharp and angular, so I used about 25 cc's of filler to soften the shoulder line. So here are the today's key takeaways, and the shoulder filler is not just about making pretty shoulders. It designs the frame around the face, and combination of the filler and the toxin will make the neckline and the shoulder line more elegant and more feminine and feminine. And the most important point is that if you use the deep subcutaneous layer, the area where we inject the filler has a few critical anatomical structures, so it can be a relatively safe procedure. And finally, for these body procedures, you must use a filler with a high G prime or high G star value. And don't forget to undercorrect. That's important, right? So it's the last thing. The aesthetic society I belong to is the ASLS, is holding our aesthetic congress on September 2nd and 3rd. So please come to the ASLS Bangkok and check out the latest trend in the K aesthetics. That's everything from me today, and thank you very much.
Thank you. Thank you. I have a question for you. How would you do you have any complication cases of filler migration or spreading of the fillers when injecting to the shoulder? Because it seems like it's a big muscles and they move all the times.
Yes, right. That's why I think I should use the high G prime or the high G star.
Even though.
Yeah, even though. Not so many in the shoulder area. But when it moves to the clavicle area, it has more like a tissue pressure is very high in here. So it's the filler I injected just like spread and migrate a bit. So there were the complications, something like that. But yeah.
Would you advise patient not to exercise?
Not for a whole lifetime, but just for at least 2 weeks. But I recommend 1 month to not exercise too hard.
And how would you decide it between select patients for fillers or toxin or about fillers and toxin? How would you decide which one do you go for filler, which one you go to toxin, or a combination?
I usually I recommend the combination, filler and the toxin also. And it's up to the patient, but I always recommend the both multimodal things.
You mentioned about, sorry. Oh, go ahead. You mentioned about trapezius toxin injections.
Yeah, right.
Have you encountered any functional complaint of the patient after?
Oh, not functional complaints. It's mostly about the effect. The patient who have complained about is just the effect. They want always wanted more effect, more volume loss effect. So yeah, that's the most thing I encountered, but not
You mean the
functional.
patients want more?
Sorry.
The patient want more injection?
Yes.
It makes
yeah,
their neck look longer.
Yeah, I know.
yeah, it's
Because the functional complication of the toxin in this particular area, particular trapezius, is so well known.
that they
what
want
is-
just more. That
Yeah.
yeah, I don't see many like functional complaints about the trapezius toxins.
Why do you think that filler that doesn't last might be better than fat transfer that may last longer, or working out or general muscle enhancement? How did you choose filler?
How do I choose the filler? For the body filler, it's actually I obviously I get the samples and I shoot the I need to see the G star and G prime values obviously, and I actually inject. I mean, I really need to inject it, like inject it and feel the filler to know which the filler is right to use in the body or not.
Is it a choice because filler is what you do and you don't do fat transfer? Or, because fat transfer, at least in the US, is more of a permanent solution. There are lipofillers such as adipose matrix,
Oh.
acellular adipose matrix injectable. There are 3 of them now. There's another one, and they are also used for, say, buttock contouring. Big body parts. And I think one of the reasons that you might be looking at filler is it's more cost effective, because here or where you're practicing, it's a
Right,
whole
right.
lot cheaper. I know that the AAM or acellular adipose matrix can cost up to $25,000, what you
right.
just did. But do you have that in your country? The
Uh,
adipose matrix?
Yeah, we have those kind of procedures, but patients are not into that kind of procedures much.
For
But
patient acceptance?
yes, it's yeah, cost effectiveness and yes, cost wise. So patients look for the filler injection a lot more than the procedure you've said.
All right. Do you have more questions? Any questions from the audience?
No, Chima, I have to leave. I have another lecture in another room.
Okay.
So can you wind up?
Yes.
Okay.
You want to finish?
Can we take the questions? I can see.
Yes, please.
It's been. Oh yeah, it's been. So you were asking how many cases I did. It's like 100 or 150, something like that. Yes, actually, half the Chinese and half Korean. Yes.
What is your common complication?
Common complication?
Yes.
It's a migration.
Migration.
Migration is
How
the
do
most
you
common.
avoid it?
Sorry?
How do you avoid it?
How do I
Prevent it. Prevent.
prevent it? I try to put the filler in the right layer, which is the deep subcutaneous layer I've mentioned. If it goes too shallow, it can migrate more. There are more chances to migrate, and it makes the uneven surfaces. So I focus to putting the filler in the right layer. Yes.
You think ultrasound has a role?
Ultrasound, what's that?
Yeah, ultrasound has a role in assisting your injection.
Ultrasound. Yeah, I think yeah, you can work it as a yeah, you can work it, but I don't usually use the ultrasound a lot.
Do you think there were a chance, a risk of vascular complication?
There are always the chances of the vascular invasion, but so far it hasn't any happened to me yet.
Okay. Thank you so much.
Thank you.
Thank you.
Thank you.
Do you have any more questions from the floor for others speakers, please?
Thank you. A very nice presentation. I want to ask about the fibrotic of the trapezius muscle. Have you encountered fibrotic tissue after repeated botulinum toxin injection here? Or do you maybe like limit your patient, like how many session can they do in lifetime to
In lifetime.
yeah to prevent the fibrotic tissue inside the muscle?
Actually, I haven't encountered the fibrotic changes in the trapezius muscles, but I have heard something like that. But for the patients who seek for the trapezius toxins, I just recommend 3 sessions. 3 sessions with one or two, 1.5 or 2 month interval for the 3 sessions, and take some rest. Take some rest at least 1 or 2 years, 1 year, and then take that again 3 sessions. And yes, 1.5 month between the sessions. Actually, I haven't seen the toxin resistance yet, but since I put the I recommend the patient to take 1 year rest, and by using that, I haven't seen any toxin resistance yet. Yeah, thank you.
I think it's a good point because the dose that we use is high,
Yes.
and it's as frequent of injections is also
Right,
increasing
right.
the risk of resistance. And also, I think we also have to concern about the functional, complication of the trapezius. It can, have the patients encounter hard of lifting things and then all that. I think that's a quite common complication. For example, like in the rehabilitations, they don't recommend to do toxin on the trapezius because of that a functional problem
Oh.
after, yes.
Oh, okay.
But for human aesthetic concern, that will be a different story. But I think we have to also, be able to educate patients, or at least
Right.
tell them that they might have encountered this kind of
Yeah,
problem.
we need to warn that
Yes.
during the, yes, I totally agree.
Thank you.
Thank you very much.
Thank you so much. Yeah, I have another question regarding the fasting. It's very interesting. At the moment, we are in the era of GLP-1. Do you think that fasting still has a role? No, we using GLP-1 at the moment, right? Do you think fasting still has a role in practice? I mean.
With my patients, I try to applicate only deep fasting with exercise, no medications, because there's no. I need. Thank you for your question. I don't try to use medication because I try to the patient do it in lifetime. Try to progressive exercise, good lifestyle. I recommend no medication. And first, yes, to help, but this is a lifestyle.
Okay. All right. Do you have more questions on the floor? Otherwise, we close the sessions. It's already 4 o'clock. Thank you so much, everybody. Thank you.